Thank you, Ambassador Burks. Good morning, everybody. Sani Bonani, Ninjani. It's great to be back in South Africa. And I just want to start by reflecting a little bit about the time when we were last here in 2000. Like many of you, I was inspired by the presentations of Nkosi Johnson when he spoke about pediatric AIDS and living with AIDS as a person, and he pleaded with us to end the epidemic. Now, Nkosi has inspired me on two levels. He inspired me when I was preparing this talk, and I kept freaking out and wondering how I was going to stand in front of you all. And I said, if Nkosi could do it as an 11-year-old, speaking in front of thousands of people at a time when HIV was so stigmatized, then I had no right to freak out. So he inspired me in that way. The second way that Nkosi inspired me was just to think about how far we have come. We've come so far in such a short time. For instance, here in South Africa, right now, 90% of infections in pediatric AIDS have been reduced as of 2015. This is no mean feat, and South Africa is to be congratulated for the progress that they have made on pediatric AIDS. I dedicate this talk to the memory of Nkosi Johnson and other young people who didn't make it, but who we are going to make a difference for. So it's usually the norm to start our discussions by reflecting on the past and then moving forward. But today I want us to do something a little bit different. Let us start with the end in mind. So welcome. Welcome on this 22nd of July, 2030. We're back in Durban to celebrate the end of pediatric HIV as a public health epidemic. Our new reality is that new infections are now virtually unheard of. Children all over the world who are living with HIV are on treatment, and they're living into adulthoods and being productive in society. We finally know what an AIDS-free generation looks like. What has evolved as well are our systems for health, our systems for health and well-being. Shown here is an interwoven fabric that represents this system. The fabric is made of many threads that, when woven tightly and maintained, becomes a fabric that protects families and supports them to have healthy and long lives. The fabric includes policies, includes diagnostics, commodities, finances, trained and competent providers, education, and strong community across many partners. When one thread is ignored, the fabric becomes frayed and weak, or may even tear so that families and communities fall through. What we are celebrating today is how we pulled the threads together to create a sustainable fabric and systems that helped us end pediatric AIDS. Health facilities are now well-equipped, able to offer acute and chronic care. Our services are people-centered, and communities are now at the forefront in offering services and in helping us determine what sort of services to give. And a mind-changing concept has taken place in the sense that community health providers are now an official cadre and are actually being paid for the work that they do. Now, it is these strengthened facilities and communities that helped us deliver on elimination of mother-child transmission. So from a world where mother-child transmission was 30 to 40%, countries started eliminating mother-child transmission, starting from Cuba, Thailand, Belarus, and Armenia, Brazil, maybe South Africa, maybe Zimbabwe, until we had a world that was completely HIV-free. The world had become blue, which signified that EMTCT had become a reality. Now I see your skepticism there in the audience. I'm sure you're wondering how we got here. So to know how we got here, we need to go back and reflect on what we did to get us to where we are today. Between 1914 and 2015, you'll remember, We made so much progress in terms of research, in terms of our programs. The research findings were rapidly being translated into program implementation. And we really learned how to design interventions to prevent mother-child transmission. Our interventions became more simplified, from 10 to 15 pills a day before, to just one pill that mothers could take and keep themselves healthy. So what was the result of all this? By 2015, 70% of pregnant women were on lifelong ART. Most of the progress was made in the period between 2011 and 2015. This coincided with the global plan for EMTCT and keeping mothers alive. And another critical factor for this was the rollout of Option B+ in most of our countries. I'm sure you all remember this. The result of this rapid scale-up was that we were able to prevent 1.6 new infections globally by 2015. PMTCT coverage rates had increased to just under 80%, and new infections had plummeted, and we had reduced them by 70%. But despite all this progress, we had fallen short of our goals of reducing infant deaths by 90%. So in 2015, the community took stock of our progress, yes, celebrating our successes, but also acknowledging that our fabric of responses still had gaps that needed to be addressed. So for one, we were losing too many women after initiating them on ART, particularly the younger mothers. As you can see from the work done through our UNICEF's OTA work in Uganda, retention of mothers of all ages dropped significantly in the first month of life after initiating therapy. And this trend went on over the following months, with the younger mothers, shown in blue, showing the worst outcomes in retention. Likewise, with our EID program, we realized we're not targeting our testing in the right places. We were testing many babies in EID platforms and many babies through PMTCT programs, but because our programs had gotten better, the yields there was just under 5% and dropping, and we were failing to test babies in high-yield platforms like pediatric wards and like OPD departments and using outreach services, and realized we had to do better on this. Regarding treatment, although by 2015 we were talking of a parity between treatment in adults and children, it was not all good news. What we realized was that we were starting treatment for children too late. What we're seeing here is a graph of the estimated number of deaths, AIDS-related deaths by 5-year age groups. You will note that the group with the highest mortality are the youngest children aged 0 to 5. Now, our age of initiating treatment was 3.8 years, meaning that for many children who were starting treatment too late, many had already died in infancy, and many had already died in the early years, early childhood. So our other area and our other challenge was adolescents. And adolescence has been a strong focus in this workshop or in this conference, and I really congratulate all the speakers and the presentations we've had on this important topic. But this remained a gap. What we realized that while pediatric infections had dropped by 70% globally, there had only been an 8% drop in the number of new infections in adolescents. And AIDS was the leading cause of death in 10 to 19-year-olds in sub-Saharan Africa, and the second cause of death globally in this age group. So a big challenge. So in 2016, we all rallied behind the Start Free, Stay Free, AIDS Free initiative that you just heard spoken about by Ambassador Burks. And basically it was aiming to recalibrate our response so that we could reach 90-90-90 by 2020, and at the end of AIDS as a public health epidemic by 2030. So we knew what had to be done. We just needed to translate these interventions into action. We needed to turn to our communities to really understand.
tusitumie mifano kama haya. Vertically infected. Vertically infected.
We need one health record per person.
Je vais mieux avec l'aide de mes voisins.
كل ما زادت معرفتنا وثقافتنا كل ما قدرنا نسوي أكثر.
เขาจะบอกว่าต้องทำอะไร
Lactating women didn't kill them? Працювати разом краще.
不同的人在不同的年龄和人生阶段都需要不同的东西。
Key affected populations.
Lazima tuungane mikono ili kuangamiza ukimwi.
Nothing about us without us.
حياكم الله في عالمنا.
欢迎来到我们的世界。
Ласкаво просимо в наш світ.
So going forward, from 2016 to 2030, we realized that we had to simplify not only the way we delivered programs, but also our language, so that we could bring the community along with us. Do you hear me? So going forward from 2016 to 2030, we realized that we had to simplify not only the way we delivered our services, but also the language that we spoke about our programs and our interventions. We built on our successes by taking what was working to scale, but even more importantly, we worked to identify solutions to our key challenges. And we targeted our programs focusing to where the unmet need was highest, but we were also careful to ensure that most vulnerable populations were not left behind. And this morning, I realized that we hadn't done enough for people living with disabilities, and so we included them. So a challenge was women living with HIV needed to initiate treatment earlier, because what the Malawi program had shown us was that the earlier you initiated treatment, the better the outcomes. So women who initiated treatment before pregnancy had a 1.4% transmission rate. Women who initiated treatment during pregnancy itself had transmission rates of 4%. But women who came too late to access these services during pregnancy had transmission rates of 13%. And those who were not on ART at all had transmission rates of 20%. So this was critical that we had to bring women in early. But our challenge was, most women all over the world do not come for antenatal care in the first trimester. So the figure was 40% globally, and in the least developed countries, it was 24%. And we had to deal with this. So how did we deal with this? We found integrated community-based programs that helped us to actually access women. What we're showing here is a program that was implemented in Guatemala, where rural health teams went out, equipped with point-of-care diagnostics for testing for syphilis, for hepatitis B, and these were integrated into activities right at the community level. Traditional midwives became part of the solution, and they referred pregnant women to receive services. And this resulted in dramatic improvement. Antenatal care increased, as you can see. HIV testing rates increased. Syphilis and HIV testing rates also hepatitis B testing rates also increased. So just by taking the services to the community level, we realized we were able to find women early and give them interventions early enough to make a difference and get the best out of our interventions. Another example of how we did context culturally grounded interventions is found from Nigeria, where the Healthy Initiative intervention was based. This was a faith-based initiative delivered through churches of all places. And what happened was that as people came in for services, the clergy called forward couples who were expecting babies, and they received health education through that mechanism. They received testing for HIV, they received testing for syphilis, they achieved the hemoglobin testing, and really a comprehensive package of antenatal care right there at the church. And what the result was, if you compared women who had attended the program and those who had not attended the program, HIV test rates were 11 times more, care before delivery was 6 times more, ART during pregnancy was almost 3 times more effective than in the communities that didn't have this approach. Just showing that, you can partner with anybody, even with the faith-based communities, to achieve really dramatic results. Now, we've been talking a lot about integration as we went along, and integration became almost a dirty word because nobody really knew how to do it. But what happened here was that we had a program in Nigeria that we learned from, where community services were delivered right there, which were very integrated. The package included task shifting, included point-of-care testing, included mother-infant service provision, and male partner involvement. So a really packaged up services at community level. And they compared this with communities that didn't have this sort of package. And what we saw was that in the communities where you had this stronger integrated approach, maternal ART, infant birth prophylaxis was higher, infant retention was higher. And so we realized that the problem of retention wasn't such a big deal if we partnered with communities, because communities were able to retain mother-infant pairs. So I know I've said community a lot, but without community, we're not going to get there. Let me turn now to what we did for labs. We knew that we had to diagnose children early. You remember children were dying too early to get on treatment. And yet our lab systems that we had really invested in were not performing for us. So what we did was we developed context-specific solutions. For instance, in China, they decided to spread out the labs. They decided to decentralize labs and established a network of 7 regional labs to reach the most rural and marginalized populations in their country. So with this approach, the turnaround time reduced from 23 days to 13 days. In Uganda, by contrast, which is being shown here on the right, they decided to centralize their labs. And so from a turnaround time of 49 days when they had 8 labs, this reduced to a turnaround time of 26 days when they consolidated their labs. And when they used transportation hubs to bring transport to the center, it reduced further to 14 days. Just showing, giving us ideas on how we could strengthen. And these ideas country took on board and ran and went on with them. Exciting developments also included the availability and scale-up of point-of-care diagnostics to complement the centralized labs. This allowed testing at primary clinics and in other settings. And so turnaround time was moved from weeks to just hours. Shown here are the results from the Malawi program that illustrate this perfectly. The introduction of point-of-care in 7 sites reduced turnaround time from 40 days to just hours. What was even more exciting was that the introduction of point-of-care was associated with doubling of the proportion of infants initiated on ART. We also became more creative with our testing since we had the technologies. So for instance, birth testing became a norm, having been pioneered by South Africa. Testing of children and family members was actually routinely done in ART clinics. HIV testing was integrated with child health services and immunization and nutrition programs. And we worked with schools and the legal systems to ensure that testing became available in our education centers. As a result, by 2020, we were able to reach 95% of all children living with HIV knowing their status, and 1.2 million children on ART by 2020. We also brought treatment closer to the children. So vans in Brazil or bicycles in rural parts of Africa, or any other solutions that really brought services closer to the children. We were creative. And despite a diminishing market for pediatric drugs, the pharmaceutical industry, perhaps VIV, surprised us by continuing to focus on drug development for children. They made first, second, and fourth-line drugs for children available. Drugs were now easy to store, simpler to administer, they were palatable, potent, and durable. Regarding adolescents, we went further and looked at the trends in the estimated number of children. Our model showed us that together with the youth bulge and the slow decline in incidence, this was an area we had to focus on. So we rolled out these packages that we've been talking about at this conference, these integrated packages of prevention that improved knowledge and skills and demand, and that dealt with policy and structural interventions. But youth-friendly services became a reality, and we stopped talking about it and just actually started doing it. Meet Halima. Halima is 16-year-old. She's receiving care in Tanzania in the PASADA program. And as part of her care, she's receiving ART, she's receiving sexual reproductive health services, and she's also learning how to be a hairdresser, all as part of strategies to keep her in care. And it was these packages of child-friendly, youth-friendly services that we rolled out and improved our services for adolescents. We also realized that we had to do more outside the health sector. So learning from studies such as the one from Lucy Kluver and all here in South Africa, we were able to show that youth-friendly solutions meant working across multi-sectors. What she showed in her study was that 52% of adolescents were non-adherent if they received no care or support. But as you offered them increasingly comprehensive packages, with the most comprehensive package, we were able to see that non-adherence rates had reduced to 18%. So this meant that our adolescents were suppressed, it meant that our adolescents were doing well on treatment, and it meant that secondary transmission was also not there. So in summary, in this phase of our programming, we found ways to scale up promising practices, such as those that I have shared today, and many that have been presented in this conference, and we went even beyond that. We changed the way we delivered our services for children and adolescents, and we ensured equity for the most marginalized. We ensured that we protected the rights of the most vulnerable. But how did we know that all this worked? What we did is we developed data systems. After a long time, we've just been talking of strengthening data systems, but now the data systems have been strengthened. Countries have moved on to electronic platforms and innovative mobile devices and smart cards, and data is now connecting people to healthcare. We got inspiration from systems such as this one in Estonia, where individuals had personalized health records from birth, and wherever you are, your records followed you. We became creative with technology. We gave our adolescents wearables. We gave them the technology so that we could track them, remind them of their medication, give them information as they needed. We worked together in a partnership, realizing that no one group could actually do it. So now here we are back. It's actually July 22nd, 2016. We have done some evidence-informed visioning of what the future could look like, but of course, we haven't moved yet. I know many of us may be feeling a bit fatigued or complacent, or maybe have just become jaded with the passing of time. I've even had many people say that we won't make it by 2030. But now is not the time to turn back. Not now, when our science is sure and we have learned how to make our programs better. Not now. An enormous opportunity presents itself for us to end the epidemic in children and adolescents. We owe it to our families around the world to come together and do something different to end the pediatric AIDS epidemic.